you're going to start out at the rods and cones. So that light's going to strike these rods and cones. That's where transduction for sight's going to occur. And then that's going to synapse with bipolar cells. Now there are a few, that's called the outer synaptic layer, and when you look at the synapses, there's actually a couple other synapses that occur here that I don't spend a lot of time on, but they synapse with some what's called amacrine cells, horizontal cells. We'll mention that one more time, but that's not a big deal. Once they synapse with the bipolar cells are going to go to this inner synaptic layer and synapse with the ganglion cells. So going to reference like first order, second order neuron stuff, you'd say, well, you have the photoreceptor cell that synapses with a bipolar cell. So then the bipolar cell becomes the first order sensory neuron in that pathway. And then it will synapse with the ganglion cell. You need to say something, Phil?
No, I just
You wanted to enjoy the heat? So the ganglion cells are what collectively come together. I always picture like wires taped together, you know what I mean? All of the ganglion cells, as they are what leave the back of the eyeball as what's called the optic nerve. So that's our first pathway. It is converging. Sometimes you could call it diverging. But convergence is generally what we see because we're taking, we haven't talked about the numbers, there are a lot of rods. There are a lot of different cones that synapse with these given bipolar cells. So really it's converging. So if you look at all the rods, generally, when you look at the, sorry I said rods, when you look at a cone, you generally only have one cone that will synapse with one bipolar cell, but rods will have multiple. And I don't really care about if you know numbers of how many, because there are many, many rods that synapse. And the reason for that is it increases light sensitivity. And so at nighttime, your rods are working. And we know that the visual image is not as clear. You don't have as much visual acuity. But I always picture like we're searching. Our eyes dilate a little. We're looking for any light that we can bring in to activate receptors. So in low light conditions, you need a lot more receptors. But you're not going to have a clear image. During the day, we use more of our cones. So cone vision is less sensitive. It doesn't need to be real sensitive. The lights are on, right? But the higher acuity of the image. And this is where I said horizontal amacrine cells. Don't spend a lot of time on those. Don't go look up what they do even more. But they've seen that these actually help to tell the brain like what parts of the retina are being stimulated more versus less, and help you to deal with different colors, like color palette. So they play a role in that we're just not going into. All right, axons. It's like everybody's. They weren't concerned during the test. Now I'm getting like a call. Everybody's concerned about the rooms now. Testing's over. Let them sweat through that. Then we'll deal with that issue. I shouldn't say that. Sounds like I'm putting them down. I don't ever mean to sound like I'm putting people down, but I do love to pick on myself and others about our idiosyncrasies of the way we do things, what we find important at what moment, that kind of stuff. It's fun for me. I don't mean to offend. All right, brain pathway. We're down to those retinal ganglion cells that we said are going to be exiting the eyeball as the optic nerve. Going back to cranial nerves, we mentioned it but didn't spend a lot of time talking about it, is that if we drew some eyeballs on here, and we have an optic nerve coming out of each eyeball, that's going to go to the optic chiasm, where some of the fibers from the right eye are going to cross over to the left side, and some of the fibers from the left eye are going to cross over to the right side. So I've said that before, but now I'm going to describe to you how that happens and what it causes. First, we got to finish out our pathway. Is if you look at the optic chiasm, when we get behind that cross area, which occurs right at the pituitary. Once you cross through the optic chiasm, now you call them optic tracts because they have fibers from both eyeballs in them, right? Some of the fibers crossed over. They got kind of mixed up as they crossed, and from there they're going to go to the thalamus. Now, I don't care, just to save y'all some time later. It says lateral geniculate, and this is a study pick, I guarantee you. It says lateral geniculate nucleus, which we've never talked about. It goes to the thalamus, just like all other sensories do, except olfaction. Right? From there, you're going to use what's called optic radiations. And optic radiations are going to carry that information from those eyes back to the primary visual area of the cerebral cortex, which is back here in the occipital lobe. So that's our pathway. That's how we're going to get there. But now we need to discuss the consequences of the crossing over. What happened that changed things for us? And I have to describe this a little bit. It takes a second to get this, and we'll draw this all out at the end, and you'll figure it out very simply. But if you think of myself, and I'm looking out at y'all, and I stand, like if I stand right in the middle of the room, and I'm looking straight down. Everything that I see over here, everything I see, that's the key word. Everything I see here and everything I see there. Everything out here is my right visual field. Everything out here is my left visual field. But we're going to divide that up. And let's say that I'm looking like diagonally at one door or the other. So right visual field, I can see this area, that's my left visual field. Well, then we divide that further into this side. If I'm looking straight at that head, but kind of off that door, this side would be my right temporal field, right temporal visual field, and this would be my right nasal visual field. This would be my left nasal visual field. That would be my left temporal. That kind of makes sense. You can follow along with that next picture that's up there too. Actually, I can flip to it, but it doesn't get much bigger. So what I'm saying, what I see out there is these round dots. Now you got it? Because I'm going to confuse you a little bit as we go along here. So right visual field has a temporal and nasal portion. My left visual field has a temporal and a nasal portion. Right you always have to, I'm trying to be clear in saying it, visual field. Because there's a huge difference between saying visual field and what we're going to see is happening at the retina. Okay, so for now, we start out with that. We understand, okay, that's what we can see. That's our visual field, and they're split. Okay, so when you look at the light rays, because our visual field, what I see is actually light. Right? All of y'all are light, or I wouldn't see it. There's energy out there. I can see it. So the light rays from any object, if you were to follow them and you look at the nasal half of the left visual field, those light rays are going to come into the eye and they're going to strike the temporal part of the retina. So the retina has a temporal and a nasal portion also, which makes a little more sense because it's already at the eye. Right? We have a nasal and a temporal portion of the retina. So if you're not getting that, that's our first step to get, is that everything, let's look at just the left. So when I look at my left visual field, temporal portion of my left visual field over here, right? And I'm closing my eye over here. And the light's coming from over where she's sitting. It's coming into my eye this way, right? So it's going to strike the nasal portion of my retina. Make sense? I think it does. I'm getting a lot of head nods. It makes sense. Okay. Remember, that's why also things get inverted. Left to right. Or not, inverted is not left to right. Sorry. They get swapped from left to right. Okay, the same thing is going to happen. That means that the nasal portion of my left visual field is going to strike the temporal portion of my retina. So because of that, and when what we see happens is crossing over, that means that when you follow the visual fields, see if this should make sense. We're just looking at the left eye here, and we see the temporal portion of my left visual field. It's going to hit, the light rays will hit the nasal portion of my left retinal. Tracking? All right. That information will then travel down to through the ganglion cells and all to the optic nerve. So when the optic nerve leaves, those fibers that struck the nasal portion of our retina are going to cross over at the optic chiasm. Same thing is going to happen over here. My temporal half of my right visual field will strike the right nasal retina, and that information will come down and it will cross over to the left. The nasal portion of my left visual field is actually hitting the right temporal retina. That will stay on the same side. So when this comes in, it will hit and it will stay on this side. It will stay on the side it's on. So we have a crossing over. Basically, you can think of it this way. The nasal retinal information is what crosses over. The confusing part is where you got it, because where did you get the nasal retinal information? From the temporal visual field, of course. I'm going to draw all this out at the end again. Actually, when I get to the picture at the end, you're going to go, why don't you just do that in the beginning? I know. We got to have slides, though. Come on. So you get info from both sides of the brain. Okay. The reason for that, you can walk through these. I've been kind of just talking over it. Because the temporal portions of the retinal information do not cross over, but the nasal retinal portions do, that gives us information on both sides. Okay, so let's draw this out. It's going to take me a second because I'm going to use different colors, but we'll use black here. So put it down here. So if that's my, whoa, I wrote it because I was thinking I needed to say, unlike when we look at muscles and things, we're not really looking anatomically at this picture, we're looking at it as left and right. I got it, left and right. Okay. So if we, and everything that was on the 3 or 4 previous slides, I put here on the left so you have it on one picture. But if I look, let's look at the left. The left temporal visual field, and then you have the right temporal visual field. We know that that information is going to come in here and hit the right retinal field. The right nasal retina. The information for this temporal field will hit the I said right on this. Let me rephrase. Temporal portion of your left visual field will strike your left nasal retina. Temporal portion from your right visual field will strike your right nasal retina. That's what I've drawn so far. Okay, so if we switch colors to help us keep track. Now you have your nasal portion of your left visual field. Going to come in and strike the temporal portion of your retina. The nasal portion of your right visual field will strike the temporal portion of your right retina. Right, still tracking? That info that hit the temporal portion of the retina is going to stay on the same side, all the way to the thalamus. Same thing is going to happen over here. Colors. That means that the nasal information, nasal retina on the left side, is actually going to come and cross over at the optic chiasm and go to the thalamus on the other side. Same thing is going to happen here. Right. So the easiest way to get confused on this is to forget whether you're discussing the visual field portion or the retina, because they're opposite, right? Temporal goes to nasal, that kind of. So if you're understanding this, we can come in here and see why this is important. You heard of pituitary tumors, optic neuritis, optic lesions from orbital fractures, glaucoma. All these different eye disorders can cause eye loss. So patients can come in and say, well, I can't see out of this portion of my eye. And that can happen because of this. This will let you know if you're tracking. Let's use purple or something for a lesion. Now, this is not going to happen, but let's say that I had a scalpel, and I very delicately went in and I cut the right optic nerve. What visual fields would I lose? Everything for the right eye. I'd lose the nasal and temporal portion. I'd lose my whole right visual field, correct? I just cut those fibers. But this is why it's important when we get to what if I came down, what if I didn't cut there? What if I cut the right optic tract? Now what did I lose? If you look at where those fibers came from, you're going to lose your right nasal visual field and your left temporal. Stare at it for a second, and then like raise a hand or something if you don't kind of get that. You just have to draw it out, kind of track it. So it's kind of weird. It is possible for somebody to come in and say, you know, like I can't see this portion, I can't see that portion. I can see out of both eyes, but I'm missing part of it. Now, is there going to be a clear-cut line? Probably not, but it's a textbook. So in ophthalmology, as confusing as this can be to some people, actually, I think I explained it so well, y'all look like you got it. Maybe not. That, or you'll get it at home later. That's visual fields. No questions? No questions? Going once, going twice, going. All right, brain pathway. We talked about everything but the collaterals. There are collaterals that come off of these nerves as they come back from the eyeball, and we're going to mention them just to tie them in and say, well, there are axon collaterals off the retinal ganglion cells that actually go to the areas that control restriction of the pupils, coordinating head movements, and that's as far as we're going to take it. If you want to go further, you can say, well, think about the superior colliculi. Something moves fast over here, my eyes and head turn towards it. Those axon collaterals are part of that, part of how that pathway works, without getting into it. The optic radiation, really only job, are on each side, and they're going to carry that information back to the primary visual area of the cortex on that side. So they're going to be on each side, back here to our occipital lobe. That's where we have our visual areas. And there are several. There are different visual areas for the size of objects, for the movement of objects, the color of objects, but we're just not going, that's another thing we're just not going into. It's very detailed, mapped out area of the brain for vision. And then we get to amblyopia. And from now until, you're going to get on the pants, you're going to get in ophthalmology, and you're going to start confusing eye disorders. And two of them you're going to confuse are strabismus and amblyopia. But here's the way to remember them. This is all you got to say. Did somebody put this bug on the desk up here just for fun? I don't care. I think it was a huge, like, water bug, we call them, but most people call them roaches, up on the... I was wondering if somebody did it because you were reading my mind because I was thinking about something in 4A. But there was a dead one up here. It wasn't here during the test. I thought maybe one of them put it. I knocked it on the floor if you want it. Bugs don't bother me. Actually, that's why I leave spiders out in the brain. I don't kill spiders. I don't care what kind of spider. Brown recluse, tarantula, I don't care. They're eating spiders. I leave them alone. My kids, that's another matter. Spider's going to die quick. Shot a big rattlesnake the other day. I was thinking, nothing went on this weekend. Trying to wake y'all back up. Nothing went on this weekend. My wife did walk right by this big old rattlesnake, and of course, comes tells me, "Go get rid of it." Why get rid of it? It's right next to like all of our wiring for our ducks and chickens. She said, well, just get the 20 gauge and shoot. I'm like, I'm going to hit a couple of ducks or something. I can't shoot in that area. Anyway, so my weapon of choice became a 22 long rifle. And it's probably the most deadly 22 I've ever had. I don't know how it shoots so straight, but it's dark, and I got one of those flashlights where you got a handle and you pull it, and I'm just holding it with one hand. And I'm bragging now. I don't know how, but I shot this rattlesnake from about 10 feet away, which is not a long shot, so that's probably why I hit it. I hit it all 5 times with that 22. I was not expecting that. The thing's still alive. It's still moving. But it was damaged, so then I chopped its head. That's what you do with snakes. Anyway, anytime there's a lot of rain, we'll start getting rattlesnakes up there. Not that many. We don't have a lot. Actually, we do. That way you'll be scared to come out to my place if you mean me harm. Could be rattlesnakes. Could be my 16-year-old knowing that nobody should be on our property. Locked and loaded, just staring at you in the scope as you drive up. You never know. All right, back to the clock. Sorry. I had to come up with something. Y'all were starting, this heat was starting to drag you down. Amblyopia. Here's what you always want to remember. Strabismus and amblyopia are 2 different things. Strabismus is lazy eye. Okay? So when you look at amblyopia, people will often call it lazy eye, but it's not lazy eye. Amblyopia is loss of vision in an otherwise normal eye. So strabismus, if you have strabismus, is your vision gone when you're a kid initially? No. If you don't, strabismus, remember, is lazy eye, where you don't have both looking at the same thing. If you let that go on without correcting it, the brain will ignore, if it's my right eye that's lazy over here, and the brain can't count on it, it will just ignore it. So strabismus, the statement, strabismus leads to amblyopia, loss of vision in an otherwise normal eye. Because the eye itself, the retina, the optic nerve, it's all fine. But because it wasn't tracking, the brain, just like we do with people, right? They annoy us enough, and we can't I'm just going to ignore them. Yeah, maybe that's just me. Okay, so loss of vision, otherwise normal eye. That means it's going to be caused by some problem with the way the eyes are. Strabismus is not the only reason. Anisotropia, I can't say that. One eye is particularly far-sighted and one eye is nearsighted. The brain will start to ignore that. So we call this, lazy brain, not lazy eye. You hear a lot of terms for it, but that'll confuse you. When you hear lazy eye, strabismus, which causes amblyopia, which is actually not lazy, it's just a loss of vision because the brain's ignoring it. Now, I didn't mention it back then last week. Somebody was talking to me up front. When we were talking about the visual fields are flipped upside down and left to right exchange when it hits the retina, and that the brain at a very early age learns to deal with that, it made me think of how they correct strabismus and amblyopia and things. They actually have glasses, and they put people in a study that flipped it again. So, the glasses caused it to hit the retina like we would expect it to look, right side up and left to right the right way. And initially, of course, now they're seeing it upside down. Even though they're looking, they're seeing it like you would have at birth if you knew that. Anyway, y'all getting what I mean? They gave them those glasses. And I don't know how long it took, but eventually the brain flipped it for them, and they could still wear those glasses. I thought that's kind of interesting. I don't know the study, the name. Hell, I don't even know if it's 100% true, but I'm telling you. I read it somewhere on the all-knowing internet. We know the internet does not lie. Y'all heard talking about, I'm so behind the times. I heard y'all talking about chat, GPT, whatever. I don't even know how you get to that. Like, y'all go on the internet every day and use chat GPT, is that it? I don't understand how that would help my life be easier. So I haven't even looked into it. But I also don't study like y'all do anymore. I know you gotta have the actual app. You can't just Google it and go.
You can Google it.
Well, what would I use it for? Actually, I know. I kind of. This guy was looking up some info.
to shoot rattlesnakes in one hit.
I think it 410's better.
You could ask that.
I don't need to ask it. I already know that. So you can ask, check. Is that the same thing? Like all the Google searches now, they give you like a summary. Yeah, I ignore that because half the time you read it, because most of what I Google is like, how do you fix the bushing on a 1998 driver's seat power track? It did. It gave me fluff.
That's because it's an automated AI from Google. There's different AIs. They're all built different.
Here's my problem. This
410 is the correct gauge.
Yeah. Especially if you live in the city. If y'all don't know this, a 410 is a great thing to shoot things in the city because most people won't even really hear it. Out at my property, nobody cares. You shoot it. Yeah, I don't know why I got on that. I don't need it. And I'm tired of websites. Nowadays, when you go to Google things, you get like all these hits. You're like, that sounds great. You start reading it, you go, how do you replace, y'all agree with me or not, and then we'll get back to it. How do you replace the window in a 2005 Tahoe driver's side? And you'll get all these things, and you're like, oh, that looks like the perfect thing. You read it, and I obviously can tell it must be they're using they're using some type of thing to write it for them. Because it always starts out with the same thing. How do you do this? And the next line will be, well, before we do that, let's talk about what's a window? A window is something you see out of, and it rolls up. They're telling me all about it. I'm like, all right, that doesn't drive y'all crazy?
You want the tools? Right, very quick, I got the tools pulled up.
The tools.
Yeah. Have it replace 2005, you said, Tahoe?
Yeah.
Don't worry, I got all the tools. I already pulled up for you. I'll send it to you.
See, I already have that knowledge up here. Normally what I'm looking for is the torque specs. I'm looking to make
T20.
Oh, that's a T20 torque, not the Titans.
Oh. Give me a second.
All right, we got to get back on track because the OCD type A people they're getting irritated by this whole conversation. You can see different things. Shape of objects, color of objects, movement. I already said this. Where your primary visual cortex has different areas for that. If you get in ophthalmology, you'll get to talk a little bit more about that. You'll probably never really pick that up. But that's it for, I thought I'd already advanced to this. That's why I was kind of breaking. Going to the ear. That, and I like talking to y'all. When you're on the podium, though, it's not conversating, it's forced listening. Right? You're having to listen to whatever I want to talk about. That's what people complain about. And I'm fine with that. Keep it interesting. Anatomy, physiology, ear. Steering equilibrium. When we look at the ear, we're going to go through basic ear anatomy. So we have the external ear, which is responsible. What we can see is actually responsible for collecting sound waves funneling those in. So we don't want big ears, but they'd be better for us, right? We have to go ears we can hear much better. Funnel more sound in there. Be out Ross Perot. Probably don't even know who he is, but that's fine. The middle ear has bones in it that actually relay sound waves that are going to be coming into the external ear. We're going to try and relay those sound waves or amplify them across to the inner ear. So in blue, you have your middle ear. I think it's getting even hotter now. Inside the inner ear out here, is where we have our cochlea and semicircular ducts, and they are going to be where we find the receptors for hearing and equilibrium. So that's the sensory portion of hearing. So the external ear, if we define out what we can see, you have the ear itself, which is called the auricle. At the top of the auricle here, that's actually called the helix, and then the lobule, your earlobe. I know that everybody knows that already. The external auditory canal lies in the temporal bone. So there's an opening in the temporal bone that leads to the eardrum. So the external ear, by definition, stops at the tympanic membrane, or what's called the eardrum. That eardrum, or tympanic membrane, has a covering of epidermis And when we look at the area of that external auditory canal, you're actually going to see we have glands in there that secrete earwax, which is a cerumen, a waxy substance in the ear that helps prevent dust, foreign objects, bacteria. Your ear should have earwax in it. So the old adage is, do not stick, if you don't want to have problems with your ears, do not stick anything inside your ear that is smaller than your elbow. If you can get your elbow in there, that's fine. But anything smaller than that, leave it alone. Now, don't raise your hand, because I know some of you are thinking, yeah, right. Because I've seen patients for many years. And I've had many, many patients come in with external ear infections, wondering why. You start talking to them. And I see people do it all the time. They take everything. Like, they'll take car keys, dig in their ears. They take the infamous Q-tips. If you ever watch a Q-tip, it really just, if your ears are like clogged with wax, you're just going to push it straight back to your eardrum. You never cleaned your ears? Don't say you haven't. You clean your ear, you're like, I'm going to get that out of there. Use that, and then all of a sudden, now I can't hear. Yeah? Well, you push the wax back against your eardrum. The wax should be there. But you'll see people come in, and you'll look through the otoscope into their ear, and it kind of looks like dry, flaky, like snake. It looks like snake skin in there. And often when you're going in there to look, sometimes you'll brush against the external auditory canal's wall, and it's real friable. It's already friable. If you scrape it with that speculum, you'll see redness develop, sometimes a little blood. But it's very dry, and that's somebody who's cleaning their ears out like crazy. It's just setting them up for an infection. You see all sorts of things. Then those things that you do this with are bunk. Y'all know that, right? There's no earwax coming out of your ear. When you know that thing? Y'all don't know what I'm talking about?
Candle.
Candling? Yeah. That's burn it without putting it by your ear. See what it looks like. Looks exactly the same. I did it. If you're all into anything I say, if you're all into it and you disagree, just keep it yourself. No, I'm kidding. If you swear by candling, I'm fine with that too. I told y'all the first day. Everybody's entitled to do whatever they want to do. I love that about people. I'm just saying an opinion. The only difference comes with when I say my opinion and I'm standing up here, people take it wrong. I can care less if you candle your ears. Tried it once, I don't think it helped. Okay. Other things that we already know, I was going to say, people who come in with their ears very dry, they are cleaning them out too much. You need to tell them to stop that. Because Q-tips were not made to go in your ears. I'm not saying I wouldn't do it. I'm saying the box says not to do it. If you read Q-tips, it tells you don't stick them in there. Then I'm wondering what they're for. I can do that without a Q-tip. The tragus. When I first started teaching this, nobody knew what the tragus was. It became a rite of passage almost in PA school when they asked me about the tragus. And I'm like, I don't know what the tragus is. But now that everybody's putting piercings all over their ears, I see people seem to know, well, yeah, that's the tragus. They haven't learned about its arch enemy, though, the anti-tragus. So there is this portion of your ear, like you're going to close off your ear that a lot of people pierce, including my daughters, is they pierce that, and you push it in, that's your tragus. And then directly opposite from it, towards the posterior, kind of inferior side, that's your anti-tragus. They've been enemies since the beginning of time. Okay. And then just behind the ear, we know from battlefield medicine type stuff, even if you weren't medical, most people in the military know what the battle signs are, mastoid process right there behind the ear. And I don't mention it a whole lot, but there's also a superficial temporal artery that's right here in front of the ear. You can't really see there. Okay, then we get into the middle ear. The middle ear is actually a cavity filled with air. Well, so is the external auditory canal, but now we've gone past the tympanic membrane. Okay, so the eardrum separates the external auditory canal from the middle ear. And normally, like I said, should be full of air. Sometimes it's not. The middle ear is going to go all the way up to the round window. Once we get to the round window, we start going into the inner ear. We're going to leave that alone for a second, and then we'll come back and discuss it. Because the middle ear has 3 little bones, 3 of the smallest bones in the body. They're called ossicles. Ossicles are what's going to transmit the movements of the eardrum. So if you take a sound wave and you bring it into the external auditory canal and it strikes the tympanic membrane, in other words, our eardrum, it will cause it to vibrate. When it vibrates, it's going to move the ossicles. So you have 3 ossicles. You have the malleus, the incus, and the stapes, in that order. So the stapes, we'll see in just a second, is attached to the tympanic membrane, well, part of it. And then it's going to articulate with the incus, and the incus will articulate with the stapes. So from lateral to medial, that's how the ossicles go. So if we blow it up and say, well, here's our malleus. So all of this is the malleus. This is called the handle. So the handle portion of the malleus is physically attached to the tympanic membrane, to the eardrum. Right. So you would say, remember, we haven't done musculoskeletal yet, so I can't say remember. And so when we look at bones, muscles, how they, joints, and musculoskeletal, we're clear on this. But here, we have bones. But anytime we look at a bone, we want to say, well, what does it articulate with? If you're looking at a humerus, we'd want to say, well, what does it articulate with proximally? What does it articulate with distally? Because in the human body, every bone in the body articulates with something except your hyoid bone, right? That bone that we find here on the skeleton doesn't articulate with anything. And that's what you break and choke somebody out on a crime mystery. All right, so we want to say articulate. So we would say that the malleus is attached to the tympanic membrane, and then laterally it's going to articulate with the incus. The incus, if you just looked at the incus, you would say, okay, well, the incus articulates laterally with the, I said that backwards. Malleus articulates laterally with the incus. But if you look at just the incus articulates laterally with the malleus and medially with the stapes. Remember, I said they're in that order. And so then the stapes that we see here, which is called the stirrup, the stapes articulates laterally with the incus, medially with an area called the oval window. So that's how they look, and if we blow them up, I don't need you to be able to label this whole thing. I just wanted to show you what the handle kind of looks like of the malleus. And then the incus that we see here has an area that's called, that's the only 2 things I need you to pick out of this. That there is a handle of the malleus and there is a process that comes off of the incus. It's called the long limb. Because when you look inside, and I'll show you a picture in a second, when you look at a normal ear and you see the tympanic membrane, it's going to have 2 slight bulges on it. And that's going to be the handle of the malleus and the long limb of the incus. So those are the only 2 that I need you to know for physical exam, and what you're kind of looking at there. I'll show you a picture in just a minute. So we have sound that's going to come into the ear. It's a funny thing that the ossicles are there to amplify sound. So somebody's whispering, they're talking kind of low, you're getting sound vibrations into the inner ear, you're trying to pick that up. When sound waves strike the tympanic membrane, the way the ossicles are set up, the tympanic membrane is very large compared to the oval window. Right, we had tympanic membrane, let's use my left ear. Tympanic membrane, then in the inner ear we had the bones, then we said the stapes will articulate the oval window. The oval window is much smaller than the tympanic membrane. So any vibrations that are out here that go to the inner ear get amplified because of the way the ossicles move. But if the sound is too loud, you move the tympanic membrane too hard or too fast, the ossicles will try to protect themselves, to protect everything. The way they're going to do that is to tighten up two of the smallest muscles in the body, called tensor tympani and stapedius. So we have to blow these up to really kind of see them. Tensor tympani comes off an area called the auditory tube. Medially, and then laterally it's going to insert into the handle of the malleus. So its whole job is to increase tension on that malleus so it doesn't vibrate so much if that's needed. Loud noises. Tensor tympani is innervated by trigeminal. TTT. Tensor tympani trigeminal. If not, you'll confuse it with stapedius. Stapedius is probably the smallest muscle in the body. You can't even see it on the picture hardly, but it's right there inside of that circle, middle. It comes off the posterior middle wall of the ear cavity and attaches to the stapes and does the same thing. Helps to dampen loud sounds. It's not innervated by trigeminal, though. It's innervated by the facial nerve. Some of this you may remember from cranial nerves. If not, when you get to tensor tympani, it's innervated by trigeminal, TPT. Stapedius, or our stapedius muscle is going to be innervated by facial. Here's what it looks like. When you look at tympanic membrane through the otoscope, we're going to be able to see the long limb of the incus and really be able to see the handle of the malleus in a normal TN. So we can see those two bulges on that tympanic membrane. We'll talk about it here in a second, but we're also looking for what's called the cone of light. That's what we should do. That would be normal. If we take the tympanic membrane away, cut out your eardrum there, we would see behind that. Right, once again, that's the handle of the malleus. Here's your long limb of the incus. But we're fully seeing, like in the back, you can see that's the stapes back here. It's just that we're looking at it from the lateral medial side. So when you do an ear exam, you're going to look in both ears. You're going to look at a lot of things, the external auditory canal, but then you're going to look specifically at the tympanic membrane. So the normal tympanic membrane is pearly gray and translucent. You're going to say that 100 times this semester and next and forever. Pearly gray and translucent. The cone, y'all already, I always forget. They've already taught you like the cone of light that you're looking for, right? So that's your landmark. I mean, I'm still going to cover it because it's part of my class, but they used to not do that in this semester. So that's a reflex off your otoscope's light. And so when we look in a right ear, we would see the cone of light, right? Inferior, anterior, comes down, goes this way. Well, so when you're looking in the ear, you're looking for that cone of light. If the cone of light is not present or it's moved, it's not where it should be, that means that eardrum is either bulging or it's retracted. Something's going on there. You really want to look at one. We did this once on one of the, as soon as everybody gets off the plane, like you've been up flying for 13 hours to Germany or something, you get off the plane and you ask whose ears are still stopped up and you can go and look in them. I mean, what else you doing? We're doing nothing for a week and a half trying to get over there. Fun thing. Eustachian tube. And we have a middle ear that has air in it. Because we have air in it, it's always going to try to equalize the atmospheric pressures. So it's going to use this tube. Now they gave this tube a lot of different names to make writing test questions easier for the instructor. I'm glad you got that sarcasm. Now it has a lot of different names. You can call it the auditory tube, the eustachian tube, pharyngotympanic tube. All it does, no matter what you want to call it, it connects the nasopharynx with the middle ear. And we know the middle ear just has air in it. And so this tube, you would say that eustachian tube opens medially into the nasopharynx and laterally into the middle ear. So normally this is closed. It doesn't just sit there open. Just like somebody told me once that they thought our esophagus just was like an open tube all the time. No, it's closed down. I mean, things. Yeah. I guess they picture their food goes in and just falls straight down. I don't know, like a piece of PVC inside you. That's how they describe it. No, not quite. But when you open this, it's going to allow air to equalize the pressure in the middle ear. If you can't equalize that pressure, you're going to start to develop problems. Right? At first, it becomes uncomfortable. We know that from getting off a plane or something. That will, if it doesn't go away or if it's increasing, you can't equalize that pressure, it'll start to be painful. And if it goes on long enough, you can develop vertigo. Vertigo is just a fancy word for dizziness, or different types of dizziness, but you're getting vertigo. That's why when you're, if you're someone who gets on a plane and your ears always get stopped up, like for an hour after you get off the plane, I always say, well, just take you some Sudafed. And depending on how long your flight is, if you're going to Germany, you can take it in the middle of the flight. But if you are taking, like I'm going to fly to Los Angeles, I know that's going to happen. Right before the plane, I get on the plane, I'll take some Sudafed because Sudafed is decongestant. I'm not don't buy any Sudafed that doesn't require a driver's license, at least not in Texas. I guess every state you got to have talking real Sudafed, not that fake stuff. Y'all buy that stuff anymore? Phenylephrine? They've pretty much proven that doesn't work at all. Try it. Yeah. If you go to the pharmacy and you show them an ID, they'll give you the good stuff. That way, if you decide someday you want to make meth, you already got it. You're going to need a lot more of it, though. So you got to get a store, different states, different months, or they'll track you. Or you got to go steal it off a train, like in Breaking Bad. Didn't they steal some off a train or something? Some methylene? I don't know. Don't be making meth. Okay, it's dangerous business. I wouldn't know, but so you're going to equalize pressure, yawn, chew gum, whatever it might be. But the other thing, and then we'll take a break. Let's cover this, and we'll do the last slide before this. Your eustachian tube is going to equalize the pressure, but because it's an open area, right? It can open and close, and you have a nasopharynx. It can have pathogens in it. Pathogens can go up through that nasopharynx, or the eustachian tube from the nasopharynx, and get into the middle ear and cause middle ear infections. Now, in adults, that's not very common. That's because when you're an infant and a child, your eustachian tubes are a little more parallel. Right? They're kind of elevated more like this. But as that child grows, you become an adult, they're a little more tilted down. Now, they're in this way, but I'm just doing an example. Right? And so they're like this, but in a child, I can't do that really. They're more horizontal, let's say. And that allows pathogens to get to their middle ear easier. Not only that, they're playing in the dirt and shoving, unless you're one of those people who keep your kid in a bubble, they're shoving things up the nose, fingers, whatever it might be. So you get more pathogens there. So kids come in and they have a middle ear infection a lot of times. If an adult comes in with an ear infection, almost always it's going to be an external auditory. One of the easiest ways to tell between a middle ear infection and an external ear infection, you grab a hold of their ear. If you have a middle ear infection, a kid's going to tell you, yeah, that still hurts. But an adult, if you grab that ear and it's infected, it hurts. And it's not very. I'm not saying rip the ear off. Literally, ear, does that hurt? Yes. Because it's infected inside of there. Versus the middle ear, that ear wouldn't hurt so much. But adults generally don't get that unless they get in like dirty hot tubs and stuff. You come back for bowling, go to the Holiday Inn, hang out with those crazy new nurses and stuff. That happens all the time. Happens all the time. Stay away from Holiday Inn hot tubs. Good way to lose weight. Just seen it happen. I've never been to that Holiday Inn. Honestly, just seen it happen. So adults going to get an external ear infection, or they're sticking car keys in there or something. Kids are going to get a middle ear infection. I'll finish this and we'll take our break. You can make your own. This is one of those opinion things as providers. You're going to hear this over and over. you heard of antibiotic resistance building up, and that just because a child is cranky, has ear pain, and you look in their ear, you don't see any redness around the TM, nothing in the canal, but they got some fluid, maybe some little bubbles back behind their TM. Are those bubbles supposed to be there? No, there's fluid in the middle ear. Does that mean that they need antibiotics? No. That's where I got to get off the podium. But I'll tell you what, certain mom's always right. I don't care, you can, mom's always right. I'll tell you this, mom comes in, a lot of them are not leaving without the antibiotics, whether it's full infection. And you can go through that whole spiel with them, and I would defend you to the end of the world that that's the correct move. They don't have the actual, they have no fever, there's no real redness, but they feel, mom thinks they got an ear infection. But here's the other side of that opinion. I have 5 kids, and my kids had a lot of ear infections. 2 of them had tubes multiple times. So when you go through that, I'm not talking as a provider now, I'm talking as a patient. We would go in, and she'd say, oh, yeah, it looks good. I'm like, yeah, well, remember 6 months ago we had the same thing, and then it progressed 2 days later, it's ear infection. Like, well, I don't see anything now. Okay, tell you what, write me a script, and I won't fill it until it's an ear infection 2 days from now. And a lot of times you get to know your pediatrician, they will do that. But, or you can stand the hard line and say, no, I'm the PA, and I know what I'm doing, not writing you a script. Throw some cameras up, because I need to send me those videos. It doesn't always go well. Anyway, hopefully y'all dealt with that. You can see what I mean. You're right, but you may lose the battle. But you have to decide that as your own provider when you look at antibiotics. It'll be a serious now, like antibiotic resistance. You really shouldn't be giving people antibiotics who don't need it. Unless you're in Mexico and you can just buy them over the counter. Let's take a break. Okay, what?
Oh, God. It's a lot to read.
Huh?
It's a lot to read. Yeah. But he's also doing like 6 slides. Like this. This is all 6 slides. I do like how he's doing this because it's like breaks it up where like it's all on one side, then you do the other side and be like, oh.
No.
Did you look at what the lecture is for Spin Lab?
Wednesday.
Chest
I completely understand where you're at.
Everybody got about it. It was like a whole.
Same thing with the other than the upper block, it's not hard. The lower side of the city. That wasn't great. It's option.
You know you have a very little conversation like that. Back before a test. Yeah, I'm not saying that I agree with you. I'm just saying you have to roll it quickly. I worked in good places. I worked in the hospital. So they do. They do it.
That's the person always wants to.
How much it is in a beer? It's like 27 bucks.
First time I saw one of those self-driving ones was in Phoenix.
Well, they had the Google ones for a while. You know what I mean?
There were Jaguars too. Oh, were they? There were Jaguars, self-driving. Like big ass cameras all over it. Yeah. You just pull up, get in, and it just drives off. It was like localized. It wouldn't go like way out. It's like 5 miles around the airport. Yeah. Uber's gonna pull it up, and I was like, "What the fuck is that?" Yeah. This was like this past October. First time I ever seen it. I thought I saw it out of place. I was like,
Did you see the one that they're at the all? There was a 4-way intersection, and all 4 of them were at the stop sign, and then like one was telling the other one to go, and then it would like go, and then the other one would go, and then it caused like an intersection to be closed off.
there was an issue where one of them like didn't stop at its destination and just took its person out somewhere.
So that's where it's like. I mean, obviously it's going to take fine tuning, but like right now, my buddy has a Tesla that does auto driving. One night we went to the casino when I was home. He was.
Yeah, I had shit so bad one time back in Bradley. We were in the back of that ride for like 6 hours. And it was like 110. I emptied an MRE bag for all my boys. Shit in the MRE bag, threw it off the back hatch. I was like, I better look away, it's about to be nasty.
That was like, it was like when you're trying to go to bed, and all you hear is.
I see, I smell it.
Golly.
I need to see you something.
Dude, I have it right here too at the same time. You're cracking me up. Driving to work on Monday. Oh no.
Thumb controller got stuck.
Stick drift.
My supplies was from Egypt. Like from Egypt, so clean in Arabic. And I always send this to him every time I see it. Now he's in special missions unit. Jeez. I told him once I get out of here, I'll call him. Oh, here's the thanks to my video.
Yeah. And then it hits their phone. There's a.
Yeah.
It was at night anyway, so obviously it's not.
Send it to me.
Well, it's that with myself. Yeah, probably. That's my name.
Is that popping up on your timeline now? Because he got it on like June 20th or something. Oh, makes you want to fight. Iran goes back to Iran. Every time we get to this, I try to make like quotes. We're in the same year together. Back in Bliss. Might be like fucking or finding. So I mean, when spy plane was flying by our carrier, which two jets just went out there. They couldn't show up. They took it down. So did you also see the laser that we have? Yeah, they shot down another Iranian spy plane. And that thing is like, so it travels at the speed of light. So all you have to do is literally target it and it's fine. That's what Rubio was saying. Like, Iran has seen stuff that he's never seen before. I didn't realize like how many planes we have. How many planes? What? How many planes the U.S. has? Oh yeah. Iran has like 15,000. We have like 15,000.
Our Marines and Army have more planes than the Iranian. Like,
That's what I think I said. The Army's got more boats than the Navy. But the Navy's got bigger boats. They got big boats.
oh,
Air Force in the sky, like Air Force, Navy, Russia, Army, Marines, and then charged 4 times.
our Marines have more than anything other than the Russians.
C-17 is a country.
Oh, they break down a lot.
It's not even that. The only one designated. There are only a few designated. There's a lot of designated
Here we go.
across the water.
I'm getting schooled on Chat GPT. sometimes I talk about stuff that I know a little about, or even if I do know something about it, I like it to seem like I don't. I like to be old school. But it's showing it's pretty interesting stuff. He taught me something. He said, hey, this is what you should do. Talking about front row right here. He said, you should go into ChatGPT. You then put your slides, and then you tell it, hey, write me a test that the average 25-year-old couldn't make higher than an 80-year-old. That's exactly what he said. Joke. Okay. That was a joke. Eustachian tube. Somebody asked, and it's a good question, when you look at the eustachian tube, what is opening at each end? There are no valves. Because you just finished, like, I understand the question, because when you look at different tubes and things in the body, you look at ureters and you talk about what's in the trigon, what's the... Renal is the one test of A&P II that if you ask questions during the test, I'm going to answer. Because renal is the one thing I know really, really well. But, so I know you're thinking about ureters and physiological valves. And all that. In the eustachian tube, that doesn't exist. It's just soft tissue. So the soft tissue comes together till you yawn, sneeze, cough, and opens that up and equalizes that pressure. No valve. And the inner ear, we made it, it's called the bony labyrinth. And now we're going to see pictures of the inner ear. But I want to start out by you thinking about the fact that when we look at the external auditory meatus, that's an opening in the temporal bone. So if I was to take, like plastic, like y'all saw in the kidneys, they fill them with the plasterized stuff. If I was to take one of those and was able to, and I filled this hole and everything inside of it, then I was able to pull it out intact with one wax figure. That would look like what we're going to see of the inner, the inner ear. But the reason I say that is that's an open cavity in the bone, and they call it the bony labyrinth. So this whole portion, this is why, I mean, I know some of y'all have learned it before. This is your temporal bone, but it's not just wide open like that. These semicircular canals and that cochlea that we see there are the bony portion of the canal. Does that make sense? Another way to think of it is if I went and filled my inner ear with fluid, well, that's not what's that. If I could run water, that's a terrible way to think. Sorry, because there is fluid in there. Never mind. Y'all get it? There's openings within the temporal bone. In other words, you can't just dissect out these structures like they sit. So you have a bony labyrinth and you have the membranous labyrinth. So there's the bony wall, and then inside of that we're going to have a membrane that's the membranous labyrinth. So there's going to be fluid between those two. So the bony labyrinth consists of several things. One, you have what's called circular canals. You have 3 of them. And then you have the vestibule, which is this area in between. It contains the oval window. And then you have the cochlea out here. That's just kind of the overview. We're going to break these down. Inside of them, you're going to have a membranous labyrinth. So this would be your temporal. All of this honeycomb-looking stuff is bone. And so the darker kind of yellowish brown line here, that's what's called the bony labyrinth. The red is the membranous labyrinth. The reason I'm saying this, people get confused between the two because between the bony wall and the membrane, there is fluid, and it is called perilymph. So there's perilymph there in blue. So this bony labyrinth that we see here is full of perilymph. Inside the membranous labyrinth, we have endolymph. So that fluid's the same throughout the semicircular canals and the cochlea. And we're going to see how that helps us with hearing and equilibrium. All right, so if you look at perilymph, it kind of has the same consistency of cerebrospinal fluid, and it surrounds the membranous labyrinth because it's in the bony labyrinth. like I said, inside of the membranous labyrinth is where you find the endolymph. When we get to the vestibule, that oval portion of the bony labyrinth, it contains two areas called the utricle that we find here, and then the saccule. And they will be connected by the duct, by a duct. So an important area, the vestibule, has the oval window. So if you remember back to last hour, the stapes connects to the oval window at the vestibule. We'll keep tying that back together to see how things actually, when we talk about how this all works. The semicircular canals are structures that are kind of like a gyroscope, like your phone knows whether it's right side up or down. So you have the anterior one that's vertical, see here, and then you have a posterior one that's vertical, and then the lateral one's going to be horizontal. So collectively, those are called the semicircular canals, and they function, as we get down to the smallest part, they function like a gyroscope to tell which way your head is. When these semicircular canals are attached to the vestibule area, the utricle, the saccules, they have a dilation called an ampulla. So you're going to see these ampulla of the semicircular duct. Those are important because that's the specific area that we're going to see the receptors for equilibrium are actually in. So for now, we have semicircular canals. They have a bony labyrinth full of perilymph. They have a membranous labyrinth full of endolymph. And then they have dilated portions where it connects to the vestibule area that are called ampulla. So one of the things we see is endolymph and perilymph actually can have fluid waves. So I threw in here Meniere's disease because from now till the last time you take pantry in your life, pantry, you always seem to get something, a question associated with Meniere's disease. You're going to hear about it a lot here. Then you're going to get out in a clinic and you're never going to see it. Maybe if you work in, like somebody talked about, yeah, I don't want to get off that. Meniere's disease is somebody has too much endolymph. Meniere's disease, clinical pearls, is you're going to hear these words. Now you can have questions. So Meniere's disease has hearing loss. It has tinnitus, ringing in the ears, and vertigo or dizziness. Those symptoms alone could be a lot of things. You could just be stuffed up. But if it's Meniere's disease, anytime you hear these descriptive words before those, is Meniere's disease. When you hear fluctuating hearing loss, and then they tie it in by saying they have roaring tinnitus and whirling vertigo. They have extremely loud tinnitus, and they have extremely bad vertigo. We're not going to break down vertigo yet, but I said vertigo is dizziness, and that dizziness can be, is the room spinning or are you spinning? There's a difference, which I'll talk about later. But from now on, every time you hear these, fluctuating hearing loss, roaring tinnitus, whirling vertigo, or a description of that, always answer Meniere's disease when you get into your clinical courses. And this is going to lead to progressive hearing loss. There was a person named Meniere. All right, innervation. If we're going to have sensations, we got to be innervating these areas. So remember back to cranial nerve 8, vestibulocochlear. We're going to have a vestibular branch and then a cochlear branch. The vestibular branch of the vestibulocochlear nerve consists of actual 3 nerves itself. It's going to send branches to the utricle, the saccule nerves, and the ampullary nerves. So these little projections you see going out here. So I boxed them off on there and say those are the branches, sensory branches of the vestibulocochlear nerve. So those nerves are there to synapse with the receptors for equilibrium. So we have first order sensory neurons, and then we're going to have motor neurons. I didn't picture them here. We're going to talk about that under ear physiology. You have sensory receptor cells for equilibrium. That means that the vestibular branch or cranial nerve 8, as it's going back, would be the first order neuron. Okay? So they're going to have that receptor potential going on. The other thing is you have sensory information coming from the receptors. You have motor neurons that are going back to those same receptors to modify their sensitivity. How sensitive they are to picking up that equilibrium or that sound. When we get into physiology, we'll see the small part. But those first order sensory neurons have to have a cell body. And as you know, we always look at, well, where are there cell bodies for these sensory neurons? Now, in general senses, touch, itch, tickle, that kind of stuff, our general senses, where are our cell bodies normally located? Dorsal root ganglion. But in this special sense, they actually have a ganglion right here by them. So there is a vestibular ganglion. So the vestibular ganglion is going to contain the cell bodies for first order sensory neurons associated with equilibrium. I always say, remember, vestibular apparatus, vestibular, equilibrium. Those two are not interchangeable, but they go together always. When you hear vestibular inputs, vestibular apparatus, vestibular portion, think about equilibrium, not hearing. So the vestibular ganglia contains this first order sensory neuron cell bodies for equilibrium. If we switch over to the cochlea or bony spiral looks kind of like a snail, and it has a supporting core called the modiolus, whatever, the center of it. We're not going to focus that much on that, but we are going to look a lot at these Y-shaped partition here. You have the scella media, the scella vestibuli, skeleton panning. And it's important that we figure out the differences between these. And if you were to cut open this cochlea, you would see that it has this Y partition in it. I'll blow that up and show you, but for now, defining it. The scella media is also called the cochlear duct. The scella media is between the forks. So I'll just draw one now. That's a cross section of your cochlea, and it's going to look like this. It has kind of a Y. And so the scella media, or cochlear duct, is here. Okay? And then you will have a scella vestibuli, skeleton panning on each side. So the scella vestibuli ends at the oval window, skeleton panning ends at the round window, which will make a whole lot more sense once we start talking about physiology. So if you look at that Y partition, the scella vestibuli, the skeleton panning contain perilymph. Just like the bony labyrinth out there contains perilymph, well, so do these areas. When you look at this cross section of it, that's just one. Each side of that contains perilymph. Okay. Another thing about these areas, these are fluid cavities. The cochlea spirals around. But if you were able to unroll it all the way to the end, it would wind up, if you take a garden hose, I'm trying to say this if I can get a picture. Let's say I have a garden hose and I have the partition that's in it, right? If you were to roll that out straight to the end, eventually the skeleton panning, scella vestibuli portions will have a connection. That's called the helicotremia. So that fluid that's going through the scella vestibuli can go through the helicotremia and make its way down the other side of that cochlea, or that cochlea, in the skeleton panning. So there's no, I'm just mentioning what's here, and I promise you it will tie together later. So here's a good blow-up, this and the next picture of the actual cochlea. But we want to focus in now and say, well, this is the scella vestibuli. This is the skeleton panning. They both contain perilymph. This scella media is what's in between here. Right? The scella media is a continuation of the membranous labyrinth that we saw earlier, so it has endolymph. And what separates these areas are different membranes. So the membrane between the scella vestibuli and the scella media on this side is called the vestibular membrane. The membrane that we find down here from the scella tympani and scella media, that membrane is called the basilar membrane. So those membranes are what form that Y partition. Here's another kind of example of that. This is actually now your scella, vestibular membrane. Here's your basilar membrane. The reason I put this picture in here is because we're going to really focus in tomorrow on this area. And overall, that's called the organ of Corti. The organ of Corti sits on the basement membrane. So we call that the basilar membrane. When I tie all this together, hopefully that will become apparent. Because we're going to look at how we move fluid through the inner ear and how does that ultimately wind up being perception of hearing. So if we look at this spiral organ, the organ of Corti, we said it's on the basilar membrane, and there is where we find the receptors for hearing. So there are hair cells that are responsible for detecting hearing. And they're arranged in this area where you have a single row of inner hair cells. These are hair cells. And then you have an outer row that contains 3 different hair cells. On each one of those, they have a hair bundle. They're called stericocilia. Stereo, hearing. There are cilia on hair cells called stericocilia, and they project off the top of those hair cells. What they're for, or what they're going to do, is carry info. Those hair cells are specialized receptor cells for hearing. And so they're not the first order neuron. They're going to synapse with the first order neurons for sensory, which in this case is the cochlear branch of the vestibular cochlear nerve. Since these are sensory neurons, we look at where their cell body is, we would say, well, the cell bodies for the sensory neurons of the cochlear branch, or you could say the cell bodies for sensory neurons associated with hearing, are found in the spiral ganglia. So I talked there a little bit about myelinated dendrites, bipolar cells. The key thing out of that whole thing, actually that second bullet you can almost ignore except for the fact that I just want you to know the spiral ganglion is where you find the cell bodies for the sensory receptors of hearing. The vestibular ganglion is where you find the cell bodies for equilibrium. And then you're going to have cell bodies that are motor neurons that are in the pons, and they actually project back out to the cochlea and semicircular ducts. That's going to like it, and it's going to set the sensitivity for you. One last part here is you have what's called the tectoral membrane. The tectoral membrane is what sits, it's this white structure here. And it sits next to or close to the stericocilia, but it's not in contact with them. So if you think about like endolymph being inside of that ear, there'd be fluid around this area. So fluid's actually in this space between them. So you have a hair cell, then you have stericocilia that are almost in contact with this tectoral membrane. What we're going to see tomorrow, I'm going to leave it here and kind of explain it, is it's not, when you really look at some actual pictures, tectoral membrane doesn't have that funky shape, but that's how they depict it. It's a whole membrane that goes around the cochlea. But the key here is going to be, if you look at the Y partition that we saw, you have the cochlea and you have perilymph, you have endolymph. and you have this structure sitting on the basal membrane. What we're going to do is send a pressure wave through the perilimb, fluid wave. I'm getting ahead of exactly what we're going to start off with tomorrow, because I'm not going to do your physiology today. I'm giving you a quick preview, because our test is next, right? But this fluid wave was set up by the fact that the middle ossicles in the middle ear were vibrating. They're pushing the oval window back and forth. The oval window is on the scala vestibuli, which goes into the scala vestibuli. It's pushing in and out of the vestibule, which is connecting to the scala vestibuli, which is full of that perilimb. So it's starting a wave. And that wave is going to travel through the cochlea in the scala vestibuli, scala tympani. Ultimately, is going to cause vibration of the basilar membrane. I'll get to it. And when it does that, it's going to move the organ of Corti. And if you look at those hairs, as they sit up there, you're going to move the basilar membrane right, along with our tectoral membrane. And as they move, you're going to move it. Those hairs are going to be pulled open and closed. They're mechanical gates. I'll show you that tomorrow. But you're going to move the tectoral membrane over those hairs by setting up pressure waves within the endolymph and the perilymph. That kind of makes sense? Get you started, and then we'll walk through each step tomorrow. Yeah?
You said that the tectoral membrane does not touch the hairs because the slide says that it is in contact.
Well, I was right. You're right. I said it that way. It's not physically connected to it, but they're sitting like on there. And actually, there's a longer one. I did that 2 weeks ago. Well, my middle finger is having to be longer. So there's a long hair and a short hair, and they kind of sit like this, but they're not physically connected to it because that tectoral membrane is going to move, and when it moves, if you have two stericocilia, one's longer, one's shorter, and they're connected by a tip link. Hopefully my visual is working. When I move things up around, because they're not in contact, but they touch, it's going to make contact, and it's going to pull, and it's going to open that tip link and allow ions to flow in. And luckily for us, that's as far as we're going to go. I'm not going to talk about what ion it is. I'm just going to say it happens when we get there. Does that make sense? I agree, yeah. It's in contact, but what I was saying earlier, I mean, it's not physically connected. We clear on that? That's as far as I'm going today, unless you got more questions. I know we're early. Hoping they get the AC fixed for y'all. It's just a good breaking point before we go into ear physiology. But ear physiology is going to go pretty quick. So you notice I got a bunch of repeat slides. So I'm going to pick it up tomorrow. Go cool off.